Welcome to the MicroGenDX Mic'd Up podcast. Discover how cutting-edge next-generation sequencing technology is revolutionizing medical diagnosis, empowering healthcare professionals with rapid and accurate identification of microbes. Our experts take you through the science behind microbiome testing so that you can make better decisions when it comes to patient care. Plus, hear stories from patients firsthand about their journey toward better health. Let's get started.
Today, we have Dr. Clayton Moliver with us, a plastic surgeon, and myself. My name is Chris Ruff, and I'm our VP of Marketing here at MicroGenDX. So, Dr. Moliver, if we could just start off with you, maybe give a quick introduction for yourself. I think it's a great place to start.
Okay, well, thanks. Thanks for inviting me to be on your podcast. I'm pretty excited about it. My name is Clayton Moliver. I'm a plastic surgeon in Houston, Texas. I'm board certified in general surgery and plastic surgery. My practice is all aesthetics. I'm a clinical professor of plastic surgery, meaning I work with the residents from the University of Texas medical branch in their plastic surgery department. And we write a lot of papers and I do a lot of research, as an add-on to my practice. I'm also on the editorial board for our international aesthetic journal, the Aesthetic Surgery Journal. So I'm very involved in research and reviewing papers, and I have a busy aesthetic practice as well. So I keep myself pretty busy.
Well, that's all great to hear, and we're excited to have you on the show today.
Well, thanks.
So, Doctor, how did you first find MicroGenDX, and what was the reason for searching, for technology like this for, your practice and for your patients?
Well, to be honest with you, I wish I had found out about it earlier, but it was the pandemic. The pandemic really kicked us into high gear, trying to find the most expeditious way to test our patients and get a result back quickly, easy for the patients, easy for us. And I asked my colleagues, and I was pointed out to MicroGenDX, and they came out. The local representative came out and met with me, and everything seemed to sync. It just seemed like the most professional, most expeditious way of testing. So that's actually how I found out about it. And then as time went on, and I interacted with the company more and more, it just seemed like a natural fit, and that segued into what we're doing now, and my special interests in breast work and how it pertains to my research interests. So that's how I found out about it.
Yeah, that's great to hear. I mean, from your lens, have you seen a significant change, in the way you practice with MicroGen being a diagnostic tool versus even traditional cultures that you may have been using in the past?
Well, that's a super interesting topic, and probably I could talk for about an hour, so you'll have to cut me off at some point. Specifically, in my practice, it's all about breast surgery. In the area of breast surgery, when we put implants in, breast implants, historically, we had problems with them getting hard occasionally, or more than occasionally. And hold on a second. So in my area of practice and my research, I've been very interested in the breast and breast surgery. And where MicroGen fits in is that for many years, we had a problem with capsular contracture, hardening of the breast implant and around the scar tissue around the implant. And early on, there was a thought, this must be bacterial colonization, a biofilm forming around the implant. And the capsule, when it was removed surgically, was cultured repeatedly for years and years and years, starting in the 1980s. And it very rarely, if ever, I mean, like almost 0% of the time, grew anything. We never were able to grow anything out. And so we still had this capsular contracture problem. So the implant companies started to make textured implants. That's where textured implants came from, for those of you listeners that are familiar with breast implants and how they work, thinking that the collagen would reorient itself to be haphazard around around the textured surface. Many of us thought that really didn't make sense because collagen lives on a microscopic level, and these textured implants is a macroscopic event. And then lo and behold, capsular contracture continued to happen. About 4 or 5 years ago, some very bright scientists took the capsule around that forms around these implants and took it back to the lab and chopped it all up and ultrasonicated it into tiny, tiny pieces and separated it. And they ran DNA sequencing, and lo and behold, it was not human DNA, which kind of sounds fun, like maybe it's aliens from another planet, but it was bacterial DNA. And lo and behold, that's what it was the whole time. And that's what got me really excited because it makes sense. We all know about and we've heard about our biome, bacteria that live around our bodies. We live in synchrony. We live in harmony with bacteria. It's on our skin. It's in our GI tract. And if it's there, it's sort of everywhere. And we have sort of a delicate balance. When one of those bacteria goes haywire and overgrows, then sometimes it gets into the tissues and it can cause infection, or it can just colonize an area that it's not supposed to be. These cultures that we run to labs are kind of 50-year-old technology, and we're still running on 50-year-old technology. Going back to the biopsies, the cultures we ran on these capsules, they came back negative, or they came back with nothing worrisome, only probably contamination, skin contamination. And the labs routinely ignore that. Well, it's estimated that 95% of the bacteria that get around implants is skin bacteria, one of 3 or 4 different skin bacteria. And that's the ones we're really looking for. And that's the ones they're ignoring and not sending to us, or they can't pick it up. They're just seeing small amounts of it. They can't really grow it. Again, it's 50-year-old technology. Along comes companies like MicroGenDX with really, state-of-the-art DNA sequencing, DNA testing, and they say, oh no, here it is. This is what you have. You have so many percent of this, so many percent of that, so many percent of this, and now we know what to go after, what to treat the patient with after we've taken out that capsule for hardening or for some new problems that are presenting themselves that are questionable. We don't know what to make of them, so-called breast implant illness. So I'm using DNA sequencing both in women that come in with complaints that they feel like their implants are perhaps making them ill, and for hardened implants. And I'm synergizing that with selecting the correct antibiotics to treat it very purposefully, evidence-based medicine instead of just shotgun medicine. So again, I can go on and on and on, but it's been a game changer for how I practice medicine and how I practice my breast surgery for these ladies that have problems with their breast implants.
That's all wonderful to hear. And, we love the fact that you've adopted new technology to, kind of pave the way forward for your practice. And, I'm sure you're talking to your colleagues about, how you're leveraging MicroGen as well. Could you help us understand, how you're actually collecting the MicroGenDX samples in your practice and your patients?
Well, I can tell you about it, but it's actually, let's just go back to it. How I'm collecting it is simple. It's a swab in the operating room or immediately after we have the specimen out, and we're swabbing the interior of the capsule, and we're swabbing the exterior of the implant because these implants have a biofilm over them. So it's really pretty simple. It's part of every surgeon, plastic surgeon that does breast surgery and takes these implants out. It's easy to do. We just swab it and put it in a special swab that looks like a normal culturette, but it's a little bit different. And we send it off to the company. The fuller answer is that it's research that's in progress. It's sampling these things are are prone to error. Our orthopedic colleagues, our urology colleagues are finding out that there are specific and best practices for culturing these specimens, and I'm starting some research to look at what are the best practices for culturing them. because it can be difficult. It's very difficult in the lab, and so we've got a great lab that's working on them. But on our end, how we culture them, how we not culture them, but take the specimen is exceedingly important. What we're doing now, taking the specimen is pretty easy, but we're trying to fine tune it to make it more and more precise.
No, that's great to hear. Which leads me to my next question. Maybe you could help the audience, kind of understand a couple of case studies where, you kind of had that aha moment where you've used MicroGen versus a traditional culture, and there was a pathogen present that just kind of blew your mind, and it's not something that would have been picked up in a traditional culture, and how you were able to leverage the MicroGen technology to not only identify, what type of microorganism was there, but also how to treat that infection with the proper antibiotic usage.
Of course. So, not too long ago in the plastic surgery literature, there was some suggestion that 95% of the bacteria in a capsule contracture case is one of three common skin bacteria. That worked well for me because I've been using a certain combination of two antibiotics to treat those bacteria that I suspected were going to be there most of the time. It turned out to be the exact same ones. I've been using that protocol for about 4 years now. But from time to time, I would treat people with that protocol, and these people would have a new implant placed. We'd do a total capsulectomy, meaning we'd take out all the bacterial laden scar tissue and put a new implant in and treat them for 6 weeks, which is my protocol with these combination of antibiotics. And 6 months later, they'd have a capsule again, and it's very frustrating. Recently, I had a patient, and I'll tell you, sometimes we see capsules that are kind of nasty looking, and we say this has got to have something in it, and we do routine cultures, and they grow nothing. About 2 months ago, I had a case. It was not a very good looking capsule, and I decided not to put new implants in. We were going to take everything out, and we're just going to wait. Maybe we were going to do some other technique of breast lift, fat transfer to increase the volume, and not put an implant back in. But I did the DNA sequencing and sent it off to MicroGen, and lo and behold, it grew out 8. I keep on saying grown out because I've been practicing traditional old-fashioned medicine for years. The DNA sequencing revealed 8 different bacteria and 3 different fungi growing within that capsule. I was blown away. In my mind, once the foreign body's gone, and this is well established surgical science, the body, if it doesn't have an overburden of bacteria or fungus, will usually clear out those things on its own. In the face of a foreign body, be it a suture remnant or a splinter or an implant, the body has a difficult time clearing out bacteria or fungi until you remove that foreign body. So this is a great example of saying, number one, it justified what I saw clinically. And I would not have had that opportunity because I've never seen that diagnosis made before until I started using DNA sequencing. So it just reinforced that there's a lot more going on here. And since then, I've had a couple of others where there's multiple pathogens, and it would not be amenable to the routine kind of antibiotics that cover gram-positive bacteria. We're seeing perhaps E. coli or some fungus, and perhaps we put a new implant and what have you back in. Now we can adjust our antibiotics to specifically go after those things, and I'm seeing really great results.
That's an incredible story, and that's what it's all about, is kind of leaning forward into the technology. And it's worst case scenario, doctor, if you wouldn't have found that, there would have been some serious problems, correct?
Yeah, I mean, personally, and I alluded to it before, we're transitioning into not calling it breast implant illness. We're defining a new name for it until it's recognized by our medical community with a real diagnosis. But we do see patients that come in with previously called breast implant illness who feel like they're not feeling well, and I think we're on the cusp of finding out what's going on there. And me personally, um, I think that some of them, at least, because first of all, it's a small minority that even have this thing. But there's some people that come in and they're feeling ill, and I think we're going to be able to say, oh look, there's bacteria here. It's colonized. It's not an infection. There's no pus. There's no fever, but they feel crappy. I think we're going to find out, at least in some proportion of that small minority of women that have this. The vast majority do fine. I think we're going to identify more and more with the aid of DNA sequencing, um, a bacteria, a couple of bacteria, a bacteria and a fungus that was the etiology. So at least we can point to something and say this was likely what this person was hypersensitive to, this inflammatory process. I think that's what's going to happen. There might be some immune modulators, immune component to breast implant illness, but I think it's going to be where we're going to be going, at least with this particular problem with breast implants and breast augmentations and reconstruction. And I think it's going to be relatively easy to diagnose. Small incision, get a swab in there around the implant, and find out what's going on, and then make a good plan.
My UTI was chronic. All of the culture tests I took for years did not find the cause of infection.
I was a week and a half from them amputating my foot.
Current testing methods typically use cultures, a method that presents limitations in identifying key organisms known to cause chronic infections.
As I would see my patients, I knew I wasn't helping them because we were limited by traditional cultures.
MicroGenDX is a better test than culture because it uses the DNA from your urine, sinus, wound, or other infected sample and matches it to their database of more than 50,000 species of bacteria and fungi with a 99% accuracy.
So I was a week and a half away from not having a leg to being healed.
MicroGenDX gave me my life back.
Ask your doctor about MicroGenDX.
If you're suffering from chronic or recurring urinary, sinus, wound, or implant infections, ask your doctor to use the most accurate testing available with MicroGenDX DNA analysis.
So, as far as, kind of moving forward, do you see this, kind of almost becoming a standard of care in your practice? Even if an infection isn't present and the MicroGenDX test becomes more of like a baseline and you have those records. So say, 2, 3, 4 years down the road, patient comes back with discomfort, you go in, do another test. Now you have your baseline of a healthy patient, and then you could see, essentially what is spiked over time and be able to even use that as a more targeted approach if there's any revision or in the surgery that needs to happen on like down the road.
That's an interesting observation. And the casual observer would say, oh, well, perhaps the company's trying to push this as something that should be done all the time and more business. But the more because we've talked about this previously, and the more I thought about it, the more I thought, it's not a far cry at all. And and here's the reason why. And this is going to get kind of nerdy, but bear with me. And I'm a little bit long-winded. When I was in medical school and going through histology, you learn about what cells look like under the microscope. Again, ancient technology. I remember our professors saying, oh, here's breast tissue under the microscope. Looks familiar? And we said, yeah, it does look familiar. He says, that's because breast tissue is nothing more than modified sweat glands, which doesn't sound too sexy or too glamorous. But if you look at it under the microscope, it's modified sweat glands. The breast tissue itself all has ducts that go out to every little lobule way out in the periphery. And all those ducts merge and go all out the nipple. Well, the nipple has ducts, 7 to 10 of them, I believe. And those ducts, for a bacteria, might as well be the Grand Canyon. And so in my mind, I've always felt that sweat glands, and this is well known, and breast tissue has plenty of bacteria just roaming through it in homeostasis. It's living in harmony with your body. We have bacteria everywhere. If you were to run a swab over my skin, there'd be tons of bacteria, all of us. We're not sterile beings. And And when I started thinking about breasts like that, and what we talked about as far as a baseline or how this all could work, um, perhaps some women, when we're putting implants in, we're supposed to, try and stay outside the breast gland. But look, breast tissue looks very much like fat, and you're going to nick it here and there, and you're going to get into a little bit of breast tissue. Perhaps, when we put a breast implant in, when we do certain types of reconstruction where there is some tissue left behind, and there's going to be scattered pieces of breast tissue, even in a mastectomy, perhaps we are doing a baseline, a genetic DNA baseline, as you've suggested, and I thought, that might be an interesting place to start, and find out what bacteria they live in harmony with or not, and what level and what's the percentage of each bacteria, because that's the information you sent us. This specimen had 4 bacteria, 60% this one and 40% that one and 10% this one. And we get a baseline, and maybe, somewhere down the road, we very easily get another sample and see what's going on. What are the percentages? What's there? It might be that breast implants don't live that well in some types of patients, and in most patients they just do fine, which is, of course, what we see. They work fine in the vast majority of women, but maybe there's a small percentage that they don't do fine. Maybe that type of bacterium doesn't do well, or that one forms a biofilm more readily, for example. So I think there's a lot to learn here, and it's going to be very interesting in the next couple of years as we do more and more research with DNA sequencing, both as a baseline, as a follow-up. Maybe it's standard of care during the surgery to get these specimens to better define what's going on a microscopic level, and in a much more advanced way than cultures, which miss a lot.
Yeah, I think, we're aligned with you on the path forward there. And, it's going to be interesting to see, how this kind of develops with the standard of care in, all specialties.
I think so. I was really interested, you guys were telling me about women with recurrent urinary tract infections getting DNA sequencing. And you've had really great breakthroughs, and my orthopedic colleagues using it for people that have, not an out and out full blown infection, but a colonization, a biofilm forming around orthopedic devices, and they're finding it, and this is evidence-based medicine. They're showing good evidence. So if it's in one, it's in the other. So it's going to be interesting to see where this all goes.
Yeah, we couldn't agree more. And, I think as you talk about urology and orthopedics, and, there's so many different disciplines, even with wound care, where, you use a word like chronic and, stalled out wounds. And, this is giving you the peek under the hood to really see, what is going on and make, great educated decisions for, better patient outcomes.
I agree.
So, doctor, to kind of close out here, why would you encourage your colleagues to use MicroGenDX?
Well, it's just better medicine. It's just better medicine. I can tell you that if you talk to general surgeons, if you talk to wound care doctors, if you talk to burn doctors, burn specialists, plastic surgeons often, and sometimes general surgeons, and my colleagues in plastic surgery, cultures are super frustrating. For example, you're often taught that don't even bother getting a culture if someone's on antibiotics because it won't grow. And it won't grow very much of anything. Well, it doesn't matter if you're on antibiotics. If you're doing DNA sequencing, who cares, as long as the specimen is taken correctly. So I think it's going to, in a lot of respects, if not all, it may replace standard culturing like we've been doing for years. And not only that, in practices and parts of medicine where we're very concerned about medical devices, we are always being told by our labs, nothing of significance grew. These are likely contaminants. Well, no, these are likely exactly what we're looking for. We're looking for staph epidermidis, which most times they just kind of throw out. They say, well, that's not a pathogen. That's just lives everywhere. Well, it lives everywhere, but it's not supposed to live inside you. And so when we find it there, they just say, oh, you must have contaminated. So I think it will become the standard of care. And so when I talk to my colleagues, I'm telling them now, you need to really consider DNA sequencing. I just think it's going to replace culturing. I still in my clinic culture a wound, but I'm right there about ready to say, well, the heck with that. I think at scale, the price will come down more and more. You guys are very reasonable with your costs. In the past, it was an expensive test, but the pandemic has kind of brought to light how we can do DNA much more efficiently. So you guys have been on the leading edge of that, and I'm thankful. It's going to be a pretty cool place to go.
Well, that's great to hear, and that's us as a company. That's what we've been striving towards is, to take NGS, you think of that with NGS and it automatically goes to a cancer patient and, exorbitant cost. We kind of pride ourselves. It's like NGS for the rest of us. It's for the masses. This is technology that needs to be in every physician's hand, no matter what specialty that they operate in. And, that's why, taking time like this today to talk to you, we can't thank you enough. Because small conversations like this snowball, and the more people that can hear.
Let me jump in and say something else.
Yeah.
One of the things that impresses me, and I don't want to make it sound like I'm just here to pump you guys along, but one of the things that impresses me and also frustrates me is, and most other people in the medical field will understand this completely. You take a culture and you wait and you wait. And you wait. And 3 days later, 4 days later, they send you back a preliminary culture because literally they put it on a petri dish and they look at it and they go, we don't see much. All right, let's just put it back in the oven for a while and let it cook for a while and incubate for a while. And at 5 days or 7 days, we get a permanent report that we already know they've missed some, or the patient's already gone through, their difficult phase, and you're shooting with lots of different antibiotics, which is not great for the patient. We're hitting everything. We're putting in very strong antibiotics when we perhaps didn't need it. I sent a culture. I keep on saying culture. I sent a specimen. I have to relearn my language to you guys, and 24, 48 hours later, it's a preliminary result. But you can tell me, whether I've got a bacterial load in there, and within a day, I've got a final report. Like a day after that, it's much, much faster and it's much more precise. So I think it's pretty cool.
Yep. We've definitely listened to, the physician population, and, turnaround time is extremely important. So that's why we have our level 1 report, which gives you, your PCR, so you can see, that bacteria load. And then from there, we give you the straightforward NGS results where with antibiotic recommendations. So, take the guesswork and the shotgun approach out of your hand and give you a diagnostic tool that is something that you can trust, just as your patients trust you.
When are you going to have the Star Trek recorder or the tricorder so you can just kind of wave it over the patient and get the DNA right there and read it to us? That's what we need.
Well, we'll get there. Let's start with NGS for the masses, and we'll put that on the back burner.
Okay, all right, that sounds good.
I love where your head's at, doctor. So, can't thank you enough for your time today. We're here for you if you need anything in the future, and looking forward to getting this out to your colleagues. So, thanks again for your time.
Yeah. Thanks for inviting me on your podcast. I'm liking the fact that you're doing it in this format, and I'm looking forward to hearing other colleagues of mine in areas of medicine talk about it some more. Thanks.
All right. Take care, doctor.
Take care. Bye-bye.
Thank you for tuning in to MicroGenDX Mic'd Up. We hope that you found our broadcast informative and helpful. If you have any questions or would like to learn more about our services, please visit our website at MicroGenDX.com. Power up your precision with MicroGenDX testing, the key to accurate diagnostics and personalized treatments. Until next time, this is MicroGenDX Mic'd Up signing off.